Good morning, good afternoon, everyone. I'm Benedict Walter from the Quality of Care Network. Thank you for joining. I see more people are trying to join, so we'll just give them another 2 minutes before we start the webinar. Thank you. Good morning, good afternoon. We are going to start. I will ask you to take a quick look at the house rule that I've posted. You are all muted, all participants, in order for the speakers today to be able to present without any background noises. And we ask you to please not start your video cameras because that would really be straining on the internet connection. We will have 3 speakers today, starting with Dr. Talia Yaha from the Ministry of Health of Tanzania, who will present how the 5-star rating system in Tanzania is helping improve the quality of care at the bigger scale, at the national level. Then we will have a presentation by Dr. Sana Moder-Diwan, who is a health specialist with UNICEF, who will present the lessons from the 5-star rating system in the country, where it's been used in over nearly 7,000 facilities, sorry. And then we'll have 5 minutes by Nana Mensah Abrampa from WHO on how quality assurance is one step toward quality improvement, and also addressing a little bit what it means under COVID-19 to try to maintain quality essential health services. I'll give the floor to our speakers. Then we'll have 30 minutes of question and answers with you through the chat. So please post your question in the chat during the presentation and we'll answer them at the end. Talia Yaha, I give the floor to you. I'm going to give you, okay. Sorry.
Bennett, I have the presentation for both of us.
Yeah, I'm bringing it here. Here we go. I'm trying. Sorry. Here we go, Sam. Sorry about that.
Okay. Good morning, good afternoon, good evening, everyone. My name is Sana Moder-Diwan. As Bennett mentioned, I'm a health specialist at UNICEF in Tanzania. The work that we're presenting, I did primarily when I was at the Ifakara Health Institute, and I'll be presenting along with Talia Yahya, who you'll hear from in just a moment. I just want to highlight that this presentation is the result of the work of many people. Importantly, that includes people from academia as well as policymakers. I also want to just draw attention to two of my colleagues who should be on this call right now, co-investigators Donat Shamba from the Ifakara Health Institute and Anna Gage from the Harvard Chan School of Public Health, and they'll help us out with question and answers in the end. So over to Talhia.
Hello. So, sorry, am I on?
Yes, you are on, Talia. That's you're on. Go on.
Okay, sorry. So my name is Dr. Talhia, as Sana has just introduced me, and I'm working at the Ministry of Health in Tanzania. So this presentation talks about the star rating system, which is going on in Tanzania at the moment, and later we'll have Sanam talking about the evaluation of this system. So the Ministry of Health started this initiative in 2014 during what was called the Big Results Now initiative. This was an initiative which was in the Ministry of in the health system, and it was designed to have very big changes in the health sector in 3 years. So we had 4 work streams. One was looking at human resource, one was looking at health commodities, one was looking at RM and CH, and one was looking at performance management. And the star rating was one of the initiatives under the performance management work stream. And so far, we've done the star rating assessments twice, in 2015 and 16 in about 7,000 facilities, and 2020 again in 7,000 plus facilities. What happened was that the star rating assessment was started as a plan, as I said, to improve the performance of the health facilities. And our main initiative was to assess the health facilities, to rate them, that is to give them a rating from 0 to 5 stars, depending on how well they perform, and to develop a quality improvement plan, which was specific to that health facility, and was dependent on the gaps that we found during the assessment.
Talia, apologies, but you're very far. Can you get closer to the microphone if possible?
Oh, sorry. Okay.
Thank you. Thank
yeah,
you.
Is that better?
Much better. Thank you.
Okay. Okay. So the ultimate goal was for 80% of the primary health facilities in the country to be 3-star rating by the year 2018. So it was approximately a 3-year endeavor. So first, we needed to develop the star rating tool, which was going to be used to assess the primary health facilities. And here we're talking about the dispensaries, the health centers, and what we call the district or council. Tool. We looked first at tools which are already on the ground, and this was several. And but eventually, through analysis, we decided that it was best to have our own tool, which is specific for this process. Next. So we developed a tool which had 12 service areas. The first service area is not listed here, but it was looking at licensing because we were assessing both public, private, and faith-based owned facilities. And the 11 service areas that you see here were the ones which were assessed and were scored. So the assessment areas came about by a joint root cause analysis by the participants. We were looking at what were the chief problems that were in our health facilities today, which, if we could address, would bring rapid changes. So this is how we came about with this 12 service areas. Next. So after assessing the health facility, we would score it, and there was a methodology of scoring, and we would come up with the stars. So a facility would score either from 0 to 5 star, depending on how well they performed. Next. And because this was supposed to be a rapid assessment, because we needed to see results of the assessment in 3 years, meaning we needed to do an assessment and have the quality improvement plans. The facilities needed to work on the quality improvement plans, and then we needed to do another assessment to find out what we had achieved. So we had a national team, and this was like TOTs, which were trained on the use of the tool. And then this team divided to go into regions and trained assessors from each of the councils. And then this would go and assess the facility. And we had a minimum of 2 people, 2 assessors, and 1 member of what we call the council health management team accompanying the assessors. For the hospital, we had a bigger team of assessors. Next. So eventually, for the baseline, we were able to assess almost 7,000 facilities. And we had, as I said, in every region that we went to, take assessors from every council. And to assess one region took approximately 4 weeks. This meant assessing each council and giving feedback at the health facility level, giving feedback at the council level, and then eventually giving feedback to the region about the performance of the whole region. And the estimated cost for assessing each facility was about $200. Going back to Sana.
I just want to point out that Talhia and her colleague Mohammed have published a nice piece in the Lancet Global Health called Raising America Quality of Care, which goes into a little more detail on the evaluation, and I'm sure we can ask Bennett to circulate that as well after the webinar. So a little bit about the evaluation and its findings. So our evaluation was driven by 3 research questions. We asked what factors are associated with variation that we were seeing in the facility's capacity to improve. Some did a very good job of improving and others didn't. 2, we asked what are the mechanisms through which facility level improvement actually happened? What did facilities do that were able to improve? And 3, how does the star rating instrument actually perform as a quality measurement? What are we measuring? Are we actually measuring quality? We used the conceptual framework developed by the Lancet Global Health Commission on high quality health systems. I won't go into detail here, but this was sort of our framing conceptual concept. We then used a variety of different data sources, about 6 in total, different modalities to get at the different parts of the framework. We really wanted to capture quality in its most comprehensive form. So we used observations of clinical visits, we surveyed providers and patients, we did in-depth interviews with providers, we audited facilities. We also did pre and post-visit interviews with patients. We, in addition to the data that Talhia and her team have collected over the past 2 rounds of data collection in the star rating assessment, we also used our data and several additional sources of data, including the service provision assessment, EHS, and geographic data. Here I just want to highlight that the ability to link our pre-visit observations and exit interviews we thought was pretty exciting. Our sample included facilities that were randomly selected in 47 districts in every region. And then once we got to the facilities, we used a convenience sample. So basically the providers and clients that were there and consented to be interviewed were interviewed. Our qualitative sample was spread across the most improved facilities and the least improved. So we used purposeful sampling to get at the largest variation that we could see, and a total of 27 of these interviews were done. We then combined the 2 types of data and did an analysis where we separated out the most improved and the least improved, and tried to understand some of our research questions from that perspective. Before I go on, I really want to highlight some of my biases going into this evaluation. I think they informed the process and have left me sort of surprised with the results, probably in a good way. I came in sort of believing that facilities know their weaknesses already, that someone from the Ministry of Health doesn't need to go to a dispensary to tell them that they are short on human resources or that they don't have waste bins or running water. I also really believe that changes in the system are primary drivers of improvement. So if facilities just had enough funding or workforce, they would be fine. And I am biased towards interventions that are participatory. And on initial evaluation or initial look of the star rating, I kind of saw this as a very top-down from the ministry, coming down to dispensaries and telling people what to do. So in answer to our first question, what factors are associated with variation? We looked at Talhia's results, and we found that 72% of facilities improved. Pretty impressive. 27% improved by 2 or more stars, 45% improved by 1 star, and 28% stayed the same or were lower on reassessment. I just want to point out here that the domain on quality of care changed the least, but also started at the highest level. So then we looked at the raw data across facility type, ownership, and their scores at baseline. And we really found no difference in facility type here. We did find that public facilities improved more than private facilities and for-profit or nonprofit private facilities, but that they also started at a lower baseline. And then here you see the strong baseline effect, where those that improved or those that started the lowest actually also improved the most. Then we took our quantitative data and mapped it. And this is work from Anna Gage. We looked at the star rating maps at baseline. So the green are the highest performing facilities and the red are the lowest performing facilities. Then we mapped them at reassessment also. And here I just want to point out that this baseline effect that we're talking about doesn't seem to be the whole story, right? If it was, we would see the same patterns here as we would here. And that's not what we're seeing. We're seeing different patterns on reassessment. So then looking at the change, so here we're mapping the change in the star rating, we do find that the greatest improvement occurred in pockets. So here around the lake zone, I don't know if you can see my pointer, here around the lake zone, we see a lot of improvement except for Mara. And then around Pwani, again, a lot of improvement. The least improvement was down in here with the exception of Mbeya. When we look at the variation, 11% of it was due to differences in regions. 14% of it was due to which district you were in within that region. But importantly, beyond these administrative boundaries, we found that there is a local effect. So facilities that were closer to other facilities that did well were more likely to do well, and vice versa. So then we loaded all of these implementation factors, we call them, into one regression. We used the consolidated framework on implementation research to identify the factors that we thought would be important. And what we found is that the population density definitely was associated with improvement. That facilities with RBF improved by 6 points more than non-RBF facilities, but that facilities that were ineligible for RBF because they scored 0 at baseline improved by even more, by 11 points. We found here that when you're controlling for the other factors, public facilities improved more than private facilities or nonprofits as we expected. But hospitals and health centers also improved more than dispensaries. And then finally, we again see this strong baseline effect that most of the improvement came from very low performing facilities. So in answer to our second question, what are the mechanisms? How did this actually happen? We used primarily qualitative data, and we identified 3 core mechanisms through which facilities improved. The first was accountability, the second was learning, and the third was group identity and benchmarking. So I'll go into a little more detail on these. So accountability-wise, we found evidence of both increased internal accountability and external accountability. So internal accountability, meaning within the health system, we found that facilities that did a good job of improving shared common language, right? They shared language between facilities and between levels of the health system. They used data to report on their performance. They used star rating data to report on their performance. And they talked about the importance of data for accountability. They recognized that this hierarchy was important, that coming from the Ministry of Health meant that somebody was watching and cared what they were doing in their facilities. They were also more likely to have the Council Health Management team involved. External accountability a lot of the providers talked about the importance of the health facility governing boards, which is an innovation in Tanzania where decisions at the facility are made by a joint group, including community members. Some talked about the suggestion boxes as being important. Some said that maybe it wasn't as important, but overall this was raised as a form of external accountability with the community. Providers talked about the importance of sweet language. They talked about how taking good care of their patients and making sure that they're happy is part of their job. And they also recognized that this, increasing quality through sweet language and better delivery of care, could increase utilization and, practically speaking, could increase the funds that come to the facility. The star rating assessment was an important learning tool, and this was also surprising to me. Almost every respondent talked about how they learned from the tool. So they learned about their weaknesses, they learned about how to deliver quality of care, they learned about what quality of care is. They learned about changes in guidelines and operating procedures, so they were able to stay current with national guidelines. And they also talked about how gaps in their pre-service education were addressed by actually participating in the star rating. So just an example from these quotes, the last one here. Another thing that I thought was good about the star rating was how they used guidelines to inspect. There were things that I realized that day I was supposed to have just by the questions that they asked. So the third mechanism, which I think is really interesting, is this group identity and benchmarking. So our qualitative evidence shows that providers, through the star rating process, identified with their facility as sort of a unit, as a team, and that they also competed with other facilities, other groups, and other teams for results. So respondents who report knowing that the star rating results, reported that they knew the star rating results of neighboring facilities. So going back to this local effect that we were seeing here in the qualitative data, we see support for that idea. So people knew what other facilities were doing. They also said that facilities that scored higher were motivating to them. So here are a few quotes from supporting this mechanism. The last one I really like. So they will be the ones to celebrate. Other facilities will be the ones to celebrate. They even ate pilau, they danced, they had a lot to drink, so it helped them. So these mechanisms were then linked with actions, things that people did on a day-to-day basis. One of these actions was advocacy. Respondents used the star rating to advocate for what they needed. And because there was this an assessment that was done by the ministry at multiple levels, people talked about how the district and the region knew what these results were. They had a shared sort of understanding, and that helped them to be able to advocate for what they needed. They talked about how the star rating made them change the way that they actually practiced. They would check themselves, second guess what they were doing. They talked about walking around with a star rating in their heads. And the third action was collaboration. Lots of discussion of how groups came together to talk about the results, to improve the results, to have meetings about the results. So then looking at the mixed data where we separated the most improved facilities from the least improved facilities, we found some factors that separated these two categories. So most improved facilities were more likely to say that they understood the bureaucracy, that they weren't overwhelmed. Least improved were more likely to say that they didn't understand how to make things move through the health system. Least improved facilities were more likely to talk about sort of shipping results off to someone else to solve. So they were less likely to talk about owning the results. So we found this more in private facilities who may have had an organizing body, in the capital or in another country. Those that were least improved mentioned frequently that supervision just wasn't happening. It wasn't happening as frequently, or the quality of supervision wasn't as good. They were also more likely to say that they didn't actually even know what their star rating was at baseline or at reassessment. All of the facilities, so this was a convergent theme, all of the facilities talked about how not having control over human resources was a challenge, and that if they had more money, they would be better at being able to improve. So this is a complicated slide, but basically here we're pulling together the mechanisms and the actions and into one sort of what I'm calling a local theory of improvement. So the star rating leads to these mechanisms: accountability, learning, and benchmarking, which are associated with these actions. This action in particular helps to increase the inputs to the facility and the health system. And then this here as an enabling situation, so you need these things, but perhaps it's not enough for you to improve quality, helps you through self-checking and collaboration to actually make that leap and to improve your processes of care. A lot of our providers talked about how improving processes or delivering better care made them happier and inspired them and motivated them to then continue to provide better care. And then this, people recognized, as I mentioned before, increases utilization, and increased utilization either through health insurance or fee-for-service, or in some facilities through pay-for-performance, would then help them to improve their inputs and increase their inputs. So to our third question, how does this tool actually perform? You know, are we measuring quality? We all improved. What did we improve in? Again, going back to this framework, we created indices that reflected the different the different parts of our framework, again, in an effort to really be comprehensive. So we created a good medical practice index, a user experience index, a management index, one that looked at diagnostic and treatment accuracy, and then, of course, the basic infrastructure and equipment. And then we looked at the change over the facilities. And what we found was that quality measure increased with each level of the star rating, except for user experience. So overall, what we're seeing here is a trend up, right? All of these indices are improving as your stars here on the x-axis, except for user experience. That, no matter what your star rating was, stayed flat. Basic infrastructure, on the other hand, this is a nice slope upward. So it looks like the star rating tool did a good job of measuring basic infrastructure and equipment, right? Star rating here only discriminates diagnostic and treatment accuracy at low levels of performance. So you're seeing a lot of change down here in the 0, 1, 2 star facilities, and then it flattens out. And then the management index, it seemed to have the strongest discriminatory power. So we see the biggest change from 0 star to 4 star. So then how do these map to the actual star? So how do our indices map to the star rating? So as I mentioned, basic infrastructure and equipment, management and good medical practice overall are associated with the star rating. Good medical practice doesn't overlap directly with a category or a section of the star rating, but in totality, star rating seems to be measuring the overall medical practice that's being delivered. We found poor correlations between our management index and the management index and the star rating. So there's some question about whether the star rating actually, whether you could pick out management and look at it separately within the star rating. And then unfortunately, diagnostic, treatment accuracy, and user experience are really not very well captured by the star rating. So just mapping this on, you see the red are the ones that performed not as well, and the green that performed better, and yellow was in between. So again, user experience, diagnostic accuracy, and need some improvement. Good medical practice and management were measured, but not reflected, didn't overlap one-to-one with the star rating tool. And then star rating does a really nice job of measuring basic infrastructure and equipment. Now here I want to bring some data in from Hannah Leslie and colleagues. This is not from this evaluation, but I think it's important here to note that infrastructure, and I think many people on this call know this, the infrastructure and the actual observed clinical quality that we see are not well correlated. So measuring infrastructure isn't enough to know whether or not we have good quality care in our facilities. And in this data, we're looking at Tanzania across 3 different types of services. We're seeing pretty flat lines here, poor correlations between infrastructure and observed clinical. So overall, how does the star rating tool perform as a quality measurement tool? I think the answer here is yes and no. There are some issues and places where the star rating can improve. But I think, as Talhia has been telling me from the beginning, this is not just a quality measurement tool. This is a quality improvement tool. As a quality improvement tool, the star rating appears to be performing very well. Just in conclusion, this evaluation does suggest that star rating assessment is supporting primary care facilities to improve quality in Tanzania. There are some revisions that need to be made to the instrument to reflect some of the areas that we talked about, especially doing a better job of measuring user experience and diagnostic accuracy. The estimate, and then the third point here is just that the assessment, there's a lot of potential here, and it should be better integrated across other quality programs in the country. I'm going to pass it back to Talhia to just review some of the next steps in her and her team's thinking on the star rating assessment.
Thank you, Sanam. So, based on the recommendations by the evaluation team, we were revising the tool so that we could have a better tool, but also adding on, as the tool has gained popularity, we have also thought an edge to add on to other indicators, for example, in the vertical programs which were not there previously. For example, the malaria, the TB, HIV, and also the NCDs and emergency preparedness. We have also developed a tool to assess the tertiary level hospitals. And we have started with what we call the regional level. These are level 2 hospitals, the regional level hospitals, and are planning to move upwards to zonal and national hospitals. After preparing the new tool and piloting it, hopefully later this year, we'll start to do the third assessment with the new tool. But we've also digitalized the process. Initially, it was very much paper-based, but now we have an offline tool that probably will help to have better quality of data and better analysis, better dashboards, better use of the data that we have. Thank you.
Thank you both. Thank you, Talhia, for setting the stage on how this fits with Tanzania's effort for quality improvement and the next step to build on this tool. And thank you, Sanam, for the detailed review of the finding of the evaluation and explaining how the star rating system is a learning tool. I'm now giving the floor to Nana Mensah-Brampa, who will talk more about what you already mentioned, the link between quality assessment and quality improvement. Nana, I'm giving the floor to you. Here we go. Please type your questions for the presenter in the chat while they present so we can start the discussion straight.
Thanks, Benny. I'll just quickly upload my slide and we can begin. Okay.
Can you share your screen? Does it work?
Yes, there's upload now.
Okay, perfect. Yeah, just put it. Perfect, thank you.
You're wonderful. So thank you, Benny. I have been asked to discuss two things. The first one is to explore quality assurance as a component of achieving quality improvement, and the second is to discuss maintaining quality essential health services during COVID-19. So one of the forefathers of quality, Joseph Juran, developed the quality triad, which is often referred to as the Juran trilogy. Three key components are highlighted within this trilogy for quality management. This includes quality planning, which involves all affected parties contributing to the design phase to increase the likelihood of a desired health outcome. The second is quality control, which includes internal monitoring to ensure continuous improvement. And then there is the aspect around quality assurance, which speaks to external evaluation, inspection, audits, regulation, among others. The third and perhaps most known is quality improvement. And this is the action of every person working to implement iterative, measurable changes to make health services more effective, safe, and people-centered. For all three areas to thrive, this needs to be underpinned by a culture of quality across the health system. Examples, as we've seen in the previous example from Talia and Sanam, include leadership, learning, accountability, and also empowering individuals and groups, amongst others. It is important to highlight that quality planning, quality control, as well as quality assurance and quality improvement is not a destination, but rather it is a journey of continuous improvement. A recent report by WHO, World Bank, and the OECD identified quality interventions across four main categories. Each of these categories is closely linked to the triad of quality and aims to apply a set of interventions to continuously improve the quality of health services. The categories include the first being the systems environment, and this looks carefully at care processes and service delivery and efforts to create supportive conditions, governance processes, and legislative environments. Examples include registration and licensing, training, external evaluations, amongst others. The second block is reducing harm for people. And this includes both the health worker and the user of health services. Examples of these interventions can speak to infection prevention control, water sanitation and hygiene, or safety as well. The third block or category of intervention speaks to improvements in clinical care, and this really speaks to delivering effective care. So examples can include team-based problem solving, collaborative improvement, clinical decision support tools, amongst others. The fourth is engaging patients, families, and communities in the design, planning, implementation, and monitoring of health services. And examples can include shared decision-making, health literacy, patient experience of care, amongst others. To the next slide. As of Tuesday, April 28th, the global count of COVID-19 cases is around 3 million. These are not just numbers, these are people. Historically, when we look at past outbreaks, for example, during the Ebola outbreak in West Africa, the impact on essential health services was profound. For example, in Liberia, a 61% decline was reported in outpatient visits. In Sierra Leone, a 39% drop in children treated for malaria and 21% drop in childhood immunization. Across the border in Guinea, primary medical consultations as well as hospitalizations dropped by more than half and vaccinations by 1/3. If not addressed in a timely manner, we could see similar trends for COVID-19. So to address this, WHO issued an operational guidance for maintaining essential health services during an outbreak. This is reflected on my left-hand side and probably on the right-hand side of your screen. Look into the next box on the screen. In applying a quality lens to health service delivery in the context of COVID, a few illustrative implications can be expanded upon. So when we take the arm of effectiveness, guidelines may not always be available to account for altered ways of working. Similarly, the response will require enhanced IPC needs, as well as challenges with safe staffing levels. And looking at people-centered care, there could be potential fear about using health services, and sometimes visitors and families may not be allowed in the hospital, and this has been recorded in some settings. Similarly, increased waiting times can be reported due to staff redeployments or postponement of non-urgent care cases. And looking at the important aspect of equity, COVID-19 control measures may limit access for certain disadvantaged groups. Likewise, it can also lead to disruption of usual systems, affecting coordination and referral mechanisms. And finally, some control measures may necessitate adaptations to allow services to continue running effectively. And this we've also witnessed in a couple of countries as well. So in closing, just with my last slide, some reflections to leave you with. The first one is that responding to COVID-19 needs to go hand in hand with the delivery of routine, quality, essential health services. And this speaks to the point and the recent guidance that WHO issued on maintaining essential health services while concurrently responding to the COVID-19 response. The second is on health workers. Health workers are the backbone of this response effort, and they need to be supported by the prevailing health systems environment. So this speaks to the need for essential commodity, data, financing, amongst others. The third aspect is on the area of learning. We need to learn alongside countries to understand, to synthesize, and to share emerging experiences to inform national planning efforts alongside the global response. Within the Integrated Health Services Department at WHO, we started to explore this area and to understand how quality directorates and quality teams are being engaged within the response effort. A fourth area is a holistic approach to quality health services, not only looking at the clinical dimensions, but looking also at the management as well as the broader public health aspects. And then finally, innovations. We're seeing across multiple countries that local innovations are emerging. We need to apply and use these local innovations that are emerging from the front line to inform national level response, as well as the broader long-term health system strengthening efforts. With that, I will pause here and hand it over to Bene to lead the discussion.
Thank you very much, Nana. We'll close the presentation here, so we have a little under 20 minutes for questions and answers. I'm taking the question from the chat box, and I will read them to the presenters. The first question is directed to Talia from Paula Quigley on what was the problem with the existing tools, and would you recommend that these tools are used globally so you can have comparison between countries?
Right. With the existing tools, there were some of the tools that we had were not Tanzanian, so they weren't been adopted or borrowed, maybe I can say, from South African tools. Other tools that we had were very disease specific. We had tools which were doing around RMSJ specifically, or HIV or malaria. A lot of the tools were not very broad. So we thought that maybe having a tool for especially this purpose would serve better. Globally, yes, probably, but I think each country would have to adapt it somehow to the local situation, because it was very much, I think the service areas were very general, but some of the specific indicators were very local as well. So it was very much based on Tanzanian context, but definitely could be used in other countries. Yes. Thanks.
Thank you. The second question is for Sam. What percentage of the hospital management boards were functional? And it's actually two questions. Did you look at the level of funding for the quality improvement plan, as well as staffing and skill mix? And this is a question from Teshome Desta.
I can take the Health Facility Governing Board question, and then I'll pass the funding question on to Talhia. So there's been some research on the Health Facility Governing Boards and how functional they are. I think part of the issue is the definition of functionality. My reading of the literature and experience with them so far is that their functionality is increasing, month by month. There are not only programs in place to support them to be able to make decisions, but they're meeting more and more frequently and are being better integrated into other programs. So there's definitely improvement. Some of the early literature definitely suggested that the health facility governing boards were struggling. I think especially in bringing lay people into meetings with providers, there's a large sort of intimidation and power factor that goes into play. And then Talhi, I'd like to pass it over to you on the funding question.
If I got it right, it was around funding in the health facility. So there were two things going on at the same time with our rating. As part of the Big Results Now program as well. One was what we call the fiscal decentralization. And this meant that we were trying to have the facilities have more control over the funding. And sorry, can you hear me?
Yes, we can hear you. Thank you. Stay close to the microphone, and then can hear you very well. Thank you.
Sorry. Okay. So the funding, and there was also something called results-based financing, whereby in some of the regions, about 8 regions, the facilities were going through an initiative, World Bank funded, which is called results-based financing. So funding, as we started assessment of the health facilities was not too good, but when we went down to the second assessment, things had improved because in between the fiscal decentralization had worked. Facilities had their own bank accounts, they collected their own funding, they could had more autonomy over use of their funds. Thanks.
Thank you very much. We have another question from Muhammad Sajil asking you what are the plans to scale and integrate SRA in existing health system, and also what is the likely frequency of the assessment?
To integrate, sorry, I didn't hear that very well.
Sorry, I couldn't hear that. Can you say that again?
Sorry, could you repeat the question? To integrate the assessment into existing health systems?
Yes, the star rating assessment into the existing health system, and also what will be the likely frequency for the assessment?
Okay, so I think I can say it's more or less somehow integrated as it is because, well, as it was supposed to be, initially it was part of the Big Results Now, but that is over. The Big Results Now program has ended, but we are still continuing with it. Probably the only problem is the funding for the assessment, which we are trying to look for ways to integrate it and link it to the health financing strategy, looking how, as we're going to universal health coverage, we can link the star rating with the health financing in order to make it more sustainable in a financial aspect. And sorry, the second question was?
And the frequency of the assessment.
The frequency. Okay, so initially it was supposed to be one every year, but so far we've been able to do one every 1.5 years. So for let's say for the past 3 years we've done 2. So I think the frequency would likely be more 1 every other year.
Okay, thank you very much. And I know you also have 2 colleagues on the call that I can speak because they are on the panelist. This is Donat and Anna, so please feel free. We have another question from Robert Chasweka. I apologize if I mispronounce your name, asking whether health indicators in the facility improving in rating. So I'm going to re-say that. When the rating improved, did the health indicators in the facility also improve?
I can take that.
Yeah.
This is a tough one, and it's sort of our dream. It would be to be able to link the star rating assessment with health outcomes. To be able to say that 0-star facilities have, worse neonatal mortality rates or other outcome indicators that are closely related to the quality of the facility, and that those improve as the quality improves. Unfortunately, we don't have that data right now. The best way to get that data would be through our HMIS system in Tanzania. We're working on it, but it's a tough thing to be able to do.
Okay, thank you very much. Question from Shamsied. Are there any further details on how the culture of quality was examined at the facility and district level? And what further work can you be doing on this?
Sorry, is it examined at the health facility? Culture of quality?
No, so the culture of quality, do you have any more details on how that changed or started to be established at the facility and district level? And what are the plans to do further work on this?
Question. I mean, I would even say that the culture of quality has changed nationally. Star rating has, really become sort of the pillar, the cornerstone of quality improvement in Tanzania. It's part of people's language. It is referred to, I think, again, referring to that paper on raising a mirror to quality of care. Talhia does a nice job of describing how the star rating sort of the response from parliamentarians on the star rating and the sort of shock and surprise at the low levels and the sort of increasing commitment to, to improving quality. So I think it would even be at the national level. There is a lot of qualitative data at the facility level from our evaluation that suggests that culture is changing. Again, everything from the way people are practicing in the moment, how they're dealing with other people, how they're dealing, with their colleagues, how they're working together, how they're thinking about their facility versus other facilities. I actually, Shams, thank you for that good question. I really think that that's one of the strengths of this program is that it really appears to be having an impact on the culture of quality.
Thank you. We have a question on the process of the evaluation from Aliza Waxman, asking if you can recommend ways to improve the approach for evaluating the implementation on the STAR in Tanzania.
I think that's for Talhia.
Really? I thought you did the evaluation. Okay. Well, one of the ways to improve the process, one of the ways was to improve the tool, as I already said. As Sanam looked at it, she found that there would have been various ways to improve the tool, which we have tried to work on. The other way was one to digitalize the process. It was very, very cumbersome as we did it the first and second time because we had paper tools, Excel sheets, storage of data. All of it was very difficult. So we digitalized the whole process, and hopefully next time we'll link it with the HMIS data to get a link on outcome. The third, as I said, was to institutionalize it more and link it with other things going on, like the licensing and health financing, so that maybe later it wouldn't have to be a whole national assessment at one go, but it could be done in pockets depending on needs. Yeah, I think that's about all.
Thank you. We have a question which is probably for Talia as well, on the quality measures that you're using in the assessment and how they compare with WHO quality of care standards for maternal, newborn, and child health.
I think that's Sanam's question, maybe.
So the measures are really consistent and reflect very sort of broad guidelines, both the quality of care standards from the WHO. Talhia and her team did a very careful job early on when they were developing the tool of making sure that the questions reflect guidelines primarily, but again, those are strongly influenced by the global guidelines.
Thank you. We have a comment, a multiple comment, and a question from Meron Tesema Bekele. The comment is to draw your attention on the fact that the Safe Delivery app, which is providing hands-on tool for monthly midwives, has actually developed a model on COVID-19 and what it means to keep mother and newborn safe. So we know that, Meron, thank you very much. We're actually trying to have a webinar specifically on the Safe Delivery app. And Meron is also asking whether the study that you presented has been published and reviewed and whether you can share it.
So Anna thank you for that question. Anna has submitted the first paper coming from this data looking at the variation question. So it's been submitted, and we'll let you know as soon as it's out. And then we have a few other papers that are ongoing and being developed right now. and hopefully published soon. Will definitely circulate.
Thank you. Another question that keeps coming from Julie Murugi. Which incentives work to facilitate the engagement of private sector providers in the quality improvement star rating mechanism?
So I can't say we had any incentives. It was a national system, and the private facilities organization was involved in the BRN lab. So they were part of the whole process, and they agreed that they would like to be a part of the assessment. So there was no additional incentive. That was it. They were, in fact, they participated very well, and it also gave a chance for the health management teams at the council level to visit their private health facilities to know what challenges they are facing. And if you wanted your council to have the better star rating as a whole, you then had to look at all your facilities, both public and private, to see how you can help them improve. So there was no additional incentive. It was just, I think, cooperation with them.
I'm going to take 3 more questions. 2 of them are related to COVID-19. One from Dr. Sylvester Nandi, asking if there is any guidance that you provide, that has been provided to frontline providers and managers on how to maintain essential health services during COVID-19. Any key quality indicators that can be developed to help track the potential impact of the pandemic on essential services. And I know that touched on what Nana briefly presented.
Yeah, thanks, Benny. And for that question, as I mentioned, WHO recently issued the guidance on maintaining essential health services during COVID. We are taking a grounds-up approach, particularly looking at the quality of health services to be able to understand what are the nuances, what are the challenges, what are the gaps, and what are countries really looking for when they're linking quality with COVID-19 response. And so we are exploring with the countries to be able to understand some of these aspects that have been raised. And once those come out, we'll definitely share with all colleagues who are on the call.
Thank you. And a follow-up question from that from Sham Siad as well. Can the work done with the star rating system to date be learned from and applied in the emerging COVID-19 context?
Sorry?
Can the work that you've done so far with the star rating system provide lessons and being applied in the new context of the COVID-19?
That is a difficult one. I'm not very sure, as the epidemic is very rapidly changing every day, and the star rating could have implied information. As for the moment, we are looking as the disease spread over the country, how to have facilities which are key and able to handle the patients. So I think maybe the data could be used on which are the highest performing facilities, which should have better quality of care, and they could be looked at as the key facilities in providing that. As I said, it's a rapidly changing situation.
And then just really quickly, taking a lesson, the benchmarking and comparison mechanism that came out of the star rating, we're actually trying to apply that mechanism to improving infection prevention and control in facilities in our target regions for UNICEF. So thinking about how to have facilities compete with each other and benchmark against each other around basic things like hand washing.
Mm-hmm. I'll take one more question. That's the last one. I know there's 2 speakers which we will not have the time to answer that question, but we can do this by email later. It's about user perception of quality of care. And Charles Amé said they did not improve between both assessment points. How important do you see user perspective, and what are the determinants of service user perspective of quality in Tanzania?
Anna?
Sure, I can address this one. So the user experience measures that were included in the star rating tool itself were sort of a combination of actual user experiences and sort of client feedback processes, such as the suggestion boxes and included client satisfaction as well. So those didn't necessarily map on to the user experience measures that were included in the evaluation tool, which focused on things like how well the information was communicated to the patient, how well they were respected, which were given in the exit interviews. So we think that the communication and respect and privacy are all very important measures, but we're not necessarily reflected in the STAR rating. So this is an area which I think is being revised. And determinants of user experience. I mean, I think these are all, you know, important behaviors to measure. There is an element of client expectations that goes into these, and sort of the reference point by which the patient is judging information and respect. But I think there's a lot more sort of research and work to be done around those measures.
Thank you. Thank you so very much. We need to close because I know people just booked an hour for this. So thank you very much, Dr. Talia, Dr. Sanam, and Nana, for your presentation. There was a lot there to learn from. Ayob and another speaker as well, another participant as well, Ayob and Uzwamaka, I have your last question, and I will direct them to the speaker after this call and get back to you on email. We will send everybody who registered for this call and obviously attended as well the link to the presentation and the recording. The recording though takes 2 days at the point because of the overload of the system, but you will have this as soon as it's ready, and I'll send you the link on email. Thank you very much for your participation. Everything is posted as well on the qualityofcarenetwork.org website. Thank you for your time, and I'll see you for the next series of webinars. Thank you to our speakers.
Thank you.
Thank you.
Thank you.